Dr. Adalja,
Yeah, I'm here.
just inviting you to say a few words to.
Oh, sorry. I thought you were introducing me.
No worries.
Sorry about that. Thank you for inviting me back. Like Rohit said, I'm a CMU alumni. I graduated in 1995. I'm an infectious disease critical care and emergency medicine physician. I work as a senior scholar at the Johns Hopkins Center for Health Security, which is a public health think tank, and I've been closely following the coronavirus outbreak from an international, national, and a local level, as well as treating patients locally with coronavirus. So I'm happy to be back, and I'm happy to take any questions that you have about this, and anything I can hopefully answer any questions that you might have, and I'm eager to hear what you're thinking about.
Perfect. Thanks so much. So we had a few questions from the online chat, so I'll go over one or two of them. And again, for anyone that just joined from the waiting room, if you do have a question, just feel free to use the hand raise feature in Zoom. And then I'll unmute you, and then you can ask your question after the first few questions we've asked. So Dr. Adalja, the first question that we received was around preparedness. So the question is, do you agree with any of the measures that the US has taken during handling this crisis? What do you think the US could have done to have better prepared for this pandemic? And what should the US do to prepare for an outbreak of something worse than this in the future?
I agree with some of the actions that have been taken. But the biggest fault, what we could have done better, is the fact that we knew that this was spreading person to person for some time in China. And the actions that were taken were not the right action, meaning that this wasn't something that was going to be contained in China. This wasn't something that was going to be a travel-related infection only. And we needed to have robust testing capacity from the outset, and not just testing people that had been to China within the last 14 days, and not just testing people with lower respiratory tract symptoms, but people with mild illness as well. And we needed to have those tests be delivered by the private sector very quickly. And there was a lot of bureaucratic foul-ups that delayed our ability to get tests. And that's really put us in the situation that we're in, that we ended up having to do extensive social distancing because this virus spiraled out of control in the United States. And we had unknown chains of transmission in places like Washington State and in New York State that became untenable. So we were left with the very blunt tool of social distancing and economic shutdowns because our testing was so bad. So that's been my biggest problem with the response, is that we were left in a situation where we were always playing catch up with this virus from the very beginning. And that's really the result of the fact that our preparation in terms of diagnostic testing was not intact from the beginning.
Thank you. Our second question was related to using masks, especially since the CDC sort of recommended people wear masks out in public now. So the question was, I'm a bit torn about using a mask in public. I'd rather have the supplies be diverted to hospitals and those who really need it. In addition, I think wearing a mask gives some false security since you can still touch your eyes and get infected. At the same time, I'm not opposed to wearing one. What are your thoughts about the general public wearing masks? And then a similar related question was about cloth masks and how much protection they actually provide.
So I'm not a fan of masks in general, and I'll try and explain why. So initially, there was a recommendation for the general public not to wear masks, and that was basically derived from the fact that we wanted to make sure that the supply for healthcare workers was intact, and we know that people that wear masks are not probably necessarily protected from getting infected. Then the guidance changed, and the change was because there was a concern about what's called asymptomatic transmission, individuals who might be infected that can still transmit the virus even though they have no symptoms. And they thought if you put masks on those people, they'll be much less likely to transmit it. However, it's unclear to me that the asymptomatic transmission that occurs is something that happens in everyday life. I think it's more likely to occur in closed situations like households or unique situations like choir practice, which is really a case. There were cases linked to people singing near each other. So I don't know that people are getting that much of a benefit from it. And I am glad that they're saying use homemade masks because we don't want them rushing to get hospital masks. And I do agree with the questioner about the false sense of security, because people may paradoxically touch their face more now because they're adjusting their mask all the time, trying to make it fit better, try to itching it. And then there's even guidance that says you don't have to wear a mask if there's no one on the sidewalk with you, but if someone comes, you need to put the mask on. But how are you going to put the mask on and not touch your face? And you're told not to touch your face. So there's a lot of different conflicting evidence there. And I do think that masks are probably not the solution here. However, the politicians have seized upon it, and now it's become basically a domino effect with governor after governor requiring those masks. So I don't think that it's something that we're going to see go away, but I don't think that there's a lot of evidence for them, and I don't think it's settled science. And I think that I myself have not worn a mask in public. I may have to now because it has become a regulation in Pennsylvania. I've worn masks obviously when treating patients, but this is something that's controversial, and it may be something that we have to get used to because I think the politicians are going to push the masks irrespective of what the evidence is.
Thanks. We'll ask one more question that got submitted, and then we'll open it up to the audience to ask questions. So we see a few hands raised, so thanks for that. So there have been multiple articles from data scientists and other folks about the idea that our attempts to flatten the curve will not actually flatten it, but simply push it out. What's your take on this analysis? Is it right? Is it wrong? Or is it not looking at the whole picture?
I think it is somewhat right, because flattening the curve is not necessarily about decreasing the number of cases. And you can still have the same area under the curve with a much more flatter curve, meaning you have the same number of cases, the same number of deaths, but that they're spread out over a longer time period. And that's the real issue, because what's driving our social distancing right now is the fact that we don't want cases to occur at such a fast rate that it exceeds hospital capacity. Hence, we try to spread those cases out. We know that this virus is contagious. We know that people are going to be infected with this virus even after we end social distancing. And the issue is, after we do social distancing, have we given hospitals enough time to build capacity? Have we gotten our personal protective equipment supply chain intact? Have we gotten more ventilators? Have we gotten more diagnostic testing? Have we fortified our health departments to be able to do contact tracing so that we can handle the number of cases that comes and they don't spread out of control and exceed hospital capacity? So yes, it is true that flattening the curve doesn't necessarily mean changing the number of cases. It just means spreading them out over time so that we can deal with them in a safer manner in our hospitals so that the hospitals don't go into crisis mode.
Cool. Thank you. So we have a question from Ashley Whiteman. So I'm going to unmute and then let you ask.
Hi, Dr. Adalja. Thanks again for doing this. We're super excited to have you back and really thankful for this opportunity. One of the questions that I had is, how contagious is COVID-19 compared to other illnesses? I know you talked about that in your first talk with us. And what's the fatality rate that we know of right now?
Sure. So this coronavirus, probably the average individual probably infects maybe 2 to 3 other people. And so that's kind of on the par of influenza, or a little bit more. But the problem is that there's so many more susceptible individuals because this is a novel coronavirus, meaning that there's no population level immunity, so that there are likely many, many more victims of this than there would be from seasonal flu. So that's why you're seeing this spread so much more rapidly than flu, in the sense that there's just so many victims that are out there for this virus because it's something that the immune system of humans has never seen before. So that's why this is more contagious than flu, but on average about 2 to 3 individuals get infected. The case fatality ratio is still something that's a matter of debate, and that has to do with the fact that we still don't know the denominator. We do not know how many people in a community have it, so our data is all severity skewed. It has a severity bias in it. But what we're learning about is that we know that this is below 1% likely. So I wouldn't pay much attention to the higher numbers that you're seeing from different countries, because where there's been extensive testing, we see the case fatality rate drop. Most people believe that the case fatality rate is somewhere between like 0.66 to 0.3-ish or somewhere in there. So it likely is more so than seasonal flu, although there are some estimates that say that it might be just a little bit more fatal than seasonal flu. But the fact is that because there is no population immunity, we've got such an attack rate that even a low case fatality ratio is going to lead to a large number of deaths, because a small percentage of a big number is still a big number.
Thank you.
Next question we have is from Rebecca. So Rebecca, you can unmute and ask.
Thanks, Rohit, and thanks, Dr. Adalja. So I was wondering what you think about the idea of reopening the economy in the next few weeks. We've seen countries in Europe going way longer in quarantine, and as well as China was in quarantine for about 11 weeks. Is it smart for the US to reopen so quickly? Do you think it's in the news to keep the stock market high, or do you think politicians will actually do this?
So I think that this is a complex question, and there's no black or white answer, that it's all gray. So I do think that if you can have, I think that you can make these decisions on a regional basis, depending upon what's locally going on with the virus, what your local hospital capacity is, what your health department staffing is, and what your diagnostic testing situation is. And there are going to be places in the United States, probably even today, that would be able to deal with the amount of cases that they would increase if they started to open things back up. And that doesn't mean it's a false alternative. I mean, it's not a false alternative. It doesn't mean that you let the virus run rampant. It means you start looking at what activities have you banned, or what economic activities have you banned. Can you open up businesses in a modified fashion right now that respect some social distancing but allow the economy to reanimate? Can you just decrease the occupancy, for example, in a restaurant? Can you allow schools to open? Because there's a lot of controversial data whether opening schools, whether closing schools was even completely fully justified, and what benefit that might have had may have only been marginal. The other issue is that there is a real cost to keeping the economy shut, and it's not just an economic cost. It actually is a cost of people's livelihoods and their ability to feed themselves. And hospitals are right now pretty much barren because they've stopped doing other types of healthcare. And how long can you allow that healthcare those healthcare needs not to be met before you start to see a measurable increase in certain diseases like heart disease or cancer, because people aren't getting their screening colonoscopies or their screening mammograms or pap smears? All of that stuff has been put on hold. And I think that that's really something that you have to weigh against these economic shutdowns. And it's not going to be that we all of a sudden have Pirates and Penguins and Steelers games. Those mass gatherings are likely going to be off the table for some time because they're too dangerous to have in this environment. But there is ways to do things safely with opening schools, with looking at businesses. And even from state to state, there's differences between what Pennsylvania permits and what Maryland permits versus what New York permits, and they're not uniform. So you can learn from those states and say, hey, this state allows private construction and public construction projects, and they didn't really have that big of a problem with it. So maybe that should be what we do. We can automatically just do that right away, looking at our list and fix that. And I think that those types of approaches that are nuanced, based on local data, are probably safe, and they're not going to be the same for every part of the country. But I do think you can do this in a responsible way that's data-driven, and you keep the politics out of it.
Thank you so much.
David, you have your hand raised, you can ask.
Great, thank you. So I was just curious, what sort of long-term trends you think we might see coming out of this experience, like in healthcare, government, and business in general?
I think it's a good question. I do think that a pandemic has the capacity to really usher in different changes in society. If you look back to like the Black Death, it led to the Peasants' Revolt and the death of feudalism. So I do think that this pandemic, because people are so electronically connected now, is going to lead to changes. And those changes are going to be big for businesses. So for example, we're using the Zoom platform. Many businesses might just say, we don't need to send our people to Chicago for a meeting. Why don't we just do a Zoom meeting instead and do it just as efficiently? So people will get used to this type of thing, and that may change business travel. People may be wary about going into big crowds now, even after social distancing ends. So that may change how amusement parks operate, how people travel. People may want to travel much less than they did before, even for recreation. You're going to see people that have gotten very used to ordering things online with Amazon or whatever it might be, and they may not think it's worth going to the mall anymore. So retail was already dying. You may see it accelerate its death. There's just going to be a lot of that type of stuff. Even movie theaters, for example. Will people just use Netflix and iTunes much more than they use the movie theater anymore? So I do think there are going to be widespread societal differences that are brought out by this. Differences in society from the society prior to what this pandemic was, that are going to be brought out by the pandemic, and the changes people have had to make even with just this mild amount of this short time of social distancing we've had in the United States.
Well, thanks. Ash has another question.
Hi, so I would listen to the Sam Harris podcast where you spoke, and I thought it was a little bit more calm than the previous episode. But on that podcast, you talked about the timeline for a vaccine. I'm wondering if we assume like the most generous or the most optimistic timeline for a vaccine, say like it's available next spring, how beneficial would that be given how long it'll take for it to come out for the population?
So when you think about vaccine development, it's usually measured in years to decades even. So this isn't something that's going to be fast. I think at the best case scenario, it's looking at 12 to 18 months, I think and that's the best case scenario if everything goes perfectly. We do have vaccines rapidly moving through clinical trials. Just today, I heard about one that moved into a phase 2 clinical trial. So that's all good news. But remember, we have to manufacture this vaccine at an industrial scale of being able to basically vaccinate the world. And that's going to take some time. So I do think that we're not going to have this vaccine in time to be able to deal with this first wave. This is going to be dealt with without a vaccine. And I do think that that's going to be a big challenge because we're going to have to move forward with this virus basically stalking us until there's a vaccine.
Thank you.
Next question is from Alex.
Hey, thank you, Doctor. I'm wondering if you can comment on how well you think hospital systems, state public health agencies, the federal government are doing in coordinating or not coordinating the purchasing of PPE, ventilators, contract physicians, and staff. Are we seeing a need for a centralized procurement system in emergency situations like this?
I do think that there's been a real lack of coordination with the federal and state and local levels here, specifically the federal level being disconnected from the other levels. And I think that's made it much more difficult for hospitals to get the equipment they need, where you basically have them bidding against each other on the markets for the same types of products that they all need. So I do think that we do have to have, in these types of emergencies, a general federal coordinating ability to get resources to the states as they need them. And usually FEMA plays that role. And I do think that this has gotten better over the last several weeks with FEMA playing a much more central role in getting ventilators. We're not hearing about ventilators being, people not getting the ventilators that they need or not getting the PPE that they need. It just took some time for the federal government to stand up this whole process, but it is a definite need during these types of emergencies because it becomes, when you have an emergency that involves multiple states, you don't want the states bidding against each other for the same assets. So I think that this was a major shortcoming in the early part of this response.
Thank you.
All right, next question is Penn.
Hey, good afternoon, Dr. Adalja. Thanks for speaking with us. Quick question about, for a lot of us are fortunate to sort of work indefinitely remotely with our jobs, the internships or coming out of the MBA. Just want to get some thoughts from you on once states begin lifting restrictions or stay-at-home orders, for the best of society or for ourselves, would you say that it's a good idea to sort of stay in place as much as we can, or really when the lockdown's lifted, the lockdown's lifted?
Each person is going to have to decide what their risk preference is. And if you're somebody that has other medical conditions or you're older, I think you're going to want to still social distance because the virus hasn't gotten anywhere. But every other person is still going to have to deal with the fact that this virus is out there. It may not make them very sick, but they could spread it on to somebody that's older. So I do think that you still have to be cautious and you still have to use common sense. And even when social distancing, when the economic shutdowns end, there's still going to be a lot of rules and regulations that are going to be in place in terms of occupancy, how many people can go into things. They may not have, even if you look at, I've already seen a leaked copy of what the White House is releasing today, that there's not going to be, bars are probably not going to be open in the same way that they were before. So there's still going to, even when you start to do that, I think there is still going to be a lot of limitations on what you can and can't do. And I guess it all still boils down to individual risk tolerance and what you think you can do. And I would still advise high-risk groups to continue to social distance as best as they can.
All right, thanks very much.
Chelsea, you're next.
Hi, Doctor. Thank you for taking the time to talk with us. My question is, I guess, we hear a lot of talk about the federal and state responses to the coronavirus outbreak, but I guess I'm curious as to how you think specifically Pittsburgh and Allegheny County is doing responding to all this, and in terms of UPMC and the hospitals around here, how how well do you think they're handling the situation? Thank you.
I think being in Pittsburgh is actually a really huge advantage during this pandemic, because in Pittsburgh, we are really fortunate that we have two major healthcare systems, UPMC and the Allegheny Health Network, that have given us an abundance of hospital beds, of ICUs, of mechanical ventilators, and of medical expertise. Especially the fact that UPMC owns about 29 hospitals or so, and has the ability to do a lot of surveillance by testing in all of these hospitals in the region. So that's been really great. I think that that's helped us, and we haven't had a surge that's been unmanageable. We've had a steady clip of patients, but not anything that I would consider calamitous or bad. I do think that the Allegheny County Health Department has been very good. We're lucky also that we have a health department. Not all counties have a health department, so we've been able to get local data pretty quickly and understand what's going on very fast. And I would even say the community hospitals here, because we do have community hospitals like St. Clair Hospital, for example, and where I'm from, I grew up in Butler Hospital, which have also stepped up here. So I do think that even our community hospitals in this area are really proactive. And I think we've had time, because we're not on the same time clock as New York, that we had time to prepare and to see what was going on and gauge our response. And I think we've done really well. And I do think that at the end of this pandemic, I'm pretty confident that Pittsburgh will probably be one of the cities that comes out okay without as much disruption to life as other cities have had. And hopefully one of the ones that can get back its economic footing earlier rather than later, based on the fact that we've had a light experience with this and we have such high hospital capacity here in the Pittsburgh area.
Cool, thanks so much. So if anyone else has questions, you can go ahead and raise your hand. In the meantime, there's a few questions submitted about developing immunity from the vaccine. So sorry, not from the vaccine, but from the virus. So if you were to contract coronavirus and recover from it, one, is it clear that you develop immunity about it? And then the other question related to that is, do you think there's a possibility that we'll be able to test people for immunity and let only those people return to work first? How do you think that would work from a political and social welfare perspective? And will people who are immunocompromised not be able to work or earn for a living?
So I do think that you will be able to test for immunity. We are already in the process of looking for antibodies in individuals who have recovered from that. It's going to be important to understand what that immunity means. Is it what we say is sterilizing immunity, meaning you can't be reinfected, or is it immunity that protects you from having severe disease, which is what we've seen with other coronaviruses, that you might be able to get reinfected after a period of time, but then the reinfection is clinically silent. So this is something that we actively need to figure out, and they are trying to measure that. And we do think that people are protected for some period of time after infection, based on the best available data that we have at this point. And there are talks about what we call immunity passports or immunity certificates. And that's going to be very difficult societally. I think it makes a lot of sense in healthcare settings to check people for antibodies and allow those people to be frontline workers dealing with coronavirus patients if they have antibodies. But it's going to be a little bit more difficult when you're thinking about social events and thinking about if certain people are allowed to do that and certain people are not allowed to do that. And we have had people that have recovered from this virus who don't make antibodies. So there may be people that are immune that are labeled non-immune because they don't have this antibody test. And there are going to be a lot of societal questions that need to be answered about these immunity certificates and if they're present. And it definitely is going to put people who are at high risk, who've been cocooned away, who didn't get infected, at a disadvantage, because they're not going to be able to do anything until the vaccine is available, or there's enough herd immunity that it's safe for them to go out. And I think that's another question we have to answer. But I think they're going to be, regardless, they're going to be people that are cocooned away no matter what happens because of their risk profile.
Related to that, I'm curious about if there would be any mutations to the virus that would allow it to be reinfected, allow people to get reinfected from it. And there were reports about people in South Korea who did originally have the virus that are now recontracting it.
Wait, sorry, can you repeat the question again? Sorry.
No worries. Related to the virus mutating and then people being able to recontract it, there were reports of people in South Korea who originally had the virus that recovered and now have it again.
So that's a questionable report, because we know that they tested positive again, and we know that the test has certain limitations of detection, and it can toggle between positive and negative depending upon the person. And we know that the test just detects the genetic material. So there can be genetic debris that may or may not be cleared. So I don't think that these are actually proven to be reinfections. It's just the test toggled between positive and negative. And I want to know why these people were tested again. But I don't think that this is evidence of reinfection. Rather, that the test has a time period where it can be positive and then it can be negative, and it's not quite at the threshold where it may be negative just below the threshold, and then it might be positive on the next one just above the threshold. So I think it is more a factor of the testing rather than reinfection.
Got it. Thank you. Do we have any other questions from the participants that are here? Lily, you can unmute and ask.
Hi, Doctor. Thank you again for your time today. So you touched upon this a little bit through some other answers, but what should our expectation be for what the timeline of this looks like where we're at today? I know that the White House is about to do their briefing, just in a few minutes, but despite like what politics wants to do and expedite things, what should our expectation be for how much longer we'll be in the quarantine phase we are now? It will slowly get lifted. But I feel like I wake up every day and it's like a week longer. So, what's your gauge on what the timeline we can expect to be?
So certain places like New York State, Los Angeles, and Washington, D.C. have extended their stay-at-home orders to May 15th. I'm hoping that doesn't become just a routine knee-jerk thing to do, because I do think that the truth is that this is really nuanced, and it's gotten all politicized because of the president and his opponents that have really made this into a war between two warring camps, and it's made it very hard to have any kind of objective or science-based position on this. And what I think, it's all going to depend on where you live. If you live in one of the hot spots like New York, I think that those stay-at-home orders may stay in place for some time. But if you live in a rural place or a rural county, I think that you may see some nuance lifting, basically on a county-to-county level. And I hope that's the approach that Pennsylvania takes, because we do have a very heterogeneous outbreak in Pennsylvania, where Philadelphia and its suburbs are disproportionately affected, whereas the rest of the state is not so much. And there are likely ways that you can start to reanimate the economy in some of those counties that are not so badly hit, that have hospital capacity. So I do think things are going to change depending upon where you live in the country and who your governor is and what your governor's relationship is with the president. Unfortunately, it's all become politicized, and I don't think you're going to find there's not going to be some perfect way to predict when this should happen, because it's so much dependent upon what's going on the national scale, and politics has polluted the entire thing, and you can't actually say anything without being pigeonholed on one side or the other. But I would say that you're going to start to see loosening, I would think, in the next couple of weeks in some states already. I don't know what will happen in Pennsylvania. I think our governor here in Pennsylvania has been someone who's trying to follow the lead of the New York governor, and we don't have the same type of outbreak there, but hopefully he's able to nuance that and treat Philadelphia different than other parts of the state, and realize that not everything is the same, and not every place has the same hospital capacity constraints. So I would say at least by the end of the month, I think we should have a better idea of what's going to happen in Pennsylvania. But if you're in a state that doesn't have that same issue, you may see loosening even within the next week or two.
Can I ask a quick follow-up question? So when you talk about letting certain areas, start to, lift restrictions, but other ones not, based on, how they've been doing. But then once we start traveling around, and it's one thing to say we can lift restrictions in this area, but no one can leave the county, but people are moving around. So how does it make sense that you can lift restrictions knowing that people are going to travel?
Yeah, so that's going to be very challenging. And that's why I think that the restrictions are not going to be lifted they're going to be lifted in more of a regional approach. So you may see certain areas acting as blocks when they restrict, and that's going to somewhat diminish the effect of travel, because people do tend to travel regionally. And I think that when you're talking about mass travel or mass transit, I do think that things like mass gatherings are still going to be off the table. So I think there's less of a concern of that than you might think. But if you're able to do this in a proper regional way, because people are still, flights are still flying, people are still traveling right now. So I think that you're going to see, it's going to be difficult again, and it's not a good answer to this, because we do know that you can't that this is very heterogeneous, that places are on different clocks, and it has to be driven by local types of consideration. So if you're a place that barely has any capacity, then you may not lift your restrictions, even if you don't have that many cases, because you're worried about people coming in and starting an outbreak there. But if you're a place that has a lot of capacity, you may look at this differently. And like I said earlier, there is not like a hard and fast rule to do it, but I do think it should be based upon what the local hospital capacity is in this specific area to be able to deal with cases, whether or not they're travel related or whether they aren't. And what we don't want to see, I think, is states starting to restrict the movement of other states. And that's already happening, for example, with Rhode Island being very aggressive about people from New York coming there. But this is going to be very challenging. But I don't think the right answer is to lift everything all at once. I think it's going to be gradual based on regions. And I think that makes the most sense. And we're going to get more cases. It's just that you have to make sure that you have the measures in place that you can deal with those cases when they come, because it's not going anywhere. And I think that's a misnomer. It's not, we know that people are going to get infected. That's what we're planning. We're just trying to flatten the curve, means spreading out the cases. So it's not that we can completely guarantee that they're not going to be flare-ups. It's just that when those flare-ups occur, that they're happening in an environment that we're prepared to handle them, unlike what New York was a month ago. If that makes sense. I think I tried to answer the best I could there.
It was great. Thank you so much.
Cool. Patrick, you had a question?
Yeah. Hi, doctor. Thank you again. I think my question is just because obviously there's a lot of news being sent out there in general. Obviously, I try to focus on the more reputable places and the CDC and the WHO and things like that. But I have seen a number of arguments that if things are lifted too quickly, there could be possibly a time in the summer where things lie a little dormant, and then another huge peak in the fall. Do you see that happening? And if so, do you think it would result in another possible kind of lockdown of sorts?
I do think that we have to be prepared that there's going to be an increase in intensity of cases in the fall. This virus hasn't gone anywhere, and it may increase its intensity in the respiratory virus season as things get colder again. And if that's the case, I do think you may see some social distancing norms be put back into place if they've been lifted. Again, I think that we're not going to be in a position where we're having mass gatherings in the fall. I think if we're having college football games, for example, they're likely to happen without fans if they're happening at all. So I do think that there is that risk. And I do think that social distancing may be increased if we get increased intensity of spread that threatens the healthcare system, as long as the risk perception stays the same. Remember, a lot of this is being driven by risk perception as well. And there's going to come a time when Americans start to adjust to the fact that this is something that's out there, that they have a risk for and that they take protective actions on their own. And they may not be tolerant of these types of things happening again. And remember, this is something that happened with Zika. I used to get a million calls about Zika virus anytime any of my friends went on vacation somewhere that had Zika. I get 0 now, and the virus is there's still a risk if you go to Puerto Rico or you go somewhere, but people adjusted their their behavior to that or became numb to it. And I think that may happen as well. And the only thing is we want that to happen when we have the hospital capacity to deal with the cases, and we have the diagnostic testing and the case contact investigation teams at the health department to do so.
Thank you.
Cool. There was a related question to what Pat asked, so I'll ask it here. There's been a lot of discussion about the effect of warmer weather on the virus. So what's your opinion or just understanding of the impact that'll have over the coming months in the summertime?
So this is the 7th human coronavirus, and 4 of those coronaviruses that we deal with every year are seasonal, where they spike in the winter and spring and decrease their transmission in the summer. And this is behaving somewhat like that in terms of its transmissibility. But and it is true that the coronavirus, if it finds itself in a place that's warm, that's sunny, and that has high humidity, may not be as viable so long on surfaces. But the thing is that this is something that has no challenge from the human immune system right now. So there still may be human-to-human transmission that occurs even during the summer. It may be just less surface transmission occurs. So I don't believe it will completely suppress the way other seasonal respiratory viruses do, but I do think that there will be probably less surface transmission, and we don't know exactly how much diminution there will be. I do suspect there'll be some diminution of transmission during the summer months in temperate climates, but that doesn't necessarily mean it's going to go away completely. And we have seen hotter places like Singapore have continual transmission. So it may be that the fact that there's no population immunity is enough for the virus to overcome the environmental challenges it will have in the hotter months.
Got it. Thanks so much. Next question is from Stephen.
Oh, thank you again, doctor. My question is in regards to testing. Do you think there is like an ideal number of tests that the U.S. should meet in regards to how many it does a day? And also, do you think that we should be basing our social distancing measures off of a percentage of positive tests rather than cases, or just raw number of cases?
Sure. So I don't think that there's a magic number of how many tests that we need to be doing per day. I think that's impossible to really understand. But what we want to do is have people being able to be tested when a doctor clinically thinks it's indicated without any kind of extraneous concern regarding supply of reagents, supply of nasal swabs. We want all of that to be out of the picture so that people can get tested much more freely and seamlessly the way we test for HIV. And we're not there yet. We're getting there. It's getting better. But that's the issue. And I do think that basing social distancing on the number of positive, or looking at the trend, what percentage of tests are positive last week versus what percent are positive this week, helps you get a better gauge than the raw number of tests. Because the tests are more a function of, you're measuring the test, how many people are getting tests. You're measuring the access to the test, not necessarily the disease. So I don't look at the number of tests, number of positives in an area. I look at the number of hospitalizations, the real hospitalization, the current hospitalizations, not past historical hospitalizations. That's one of my pet peeves about the Allegheny County data, that they say past and present hospitalizations, not accounting for people who died as well as people who've been discharged. We want to know how many people are in the hospital today and how many new people got admitted in the last 24 hours. That's a really important number. So that, the percent positive of tests, those are much more important figures to really gauge what the outbreak is doing in your community.
Cool. Thanks, Stephen. Chelsea has another question.
Hi, doctor. Thank you again. So I guess I kind of have a two-part question. One is, you heard from the beginning that, people who are more at risk for this virus are older people, people with pre-existing conditions, things like that. But, I've heard in the news, and I'm sure we all have, that there have been some people, under the age of 40, no pre-existing health conditions that, like heart or lung conditions, that got this virus and got very, very sick. I know that I guess my first question is, from the research that you've read, do we have any inkling as to why, aside from just, genetic things that are unknown? And then the second part is, most of us MBA students being in that young and healthy group, once social distancing restrictions are lifted, how worried do you think we should be, I guess? Thank you.
So while it's true that in this outbreak, that the people that are getting severe illness and that are dying tend to be those that are in advanced age and those that have other medical conditions like diabetes or obesity, for example. It's not true that that means everybody else is impervious. And we see this even with flu, that there are otherwise young, healthy people that will die. It's just that the majority of cases are going to be in those high-risk groups. And it's going to be, and if you look at the case fatality ratios of people, it really does go up when those comorbidities are present or when you're in each decade of life has passed. So people that are 30 are less likely to die than people that are in their 40s. So it is definitely lower, but it doesn't mean that it's completely ironclad. And you do have to take risks. You do take a risk, and you should be alert if you do get infected to the symptoms that you have, and try and decide and trying to decide when the threshold is that you need to go see a doctor if you're getting short of breath or those types of things. And you can see young people get that. And the second part of the question was, should we I forgot the second part now.
How worried should we be once social distancing restrictions are lifted as young people, I guess? But I think you kind of already answered that, so thank you.
And it's individual risk tolerance. I think there's a lot of that that's going to end up playing a role, just like it does during flu season.
Thanks so much. Our next question is from Chris.
Yeah, so thank you so much, doctor, for joining us. So I understand there's a number of pre-existing drugs that doctors are hoping will help from a therapeutic perspective. One thing I've been a little puzzled with is, since we've been dealing with this globally for a number of months, why it's taking so long to determine the efficacy of these drugs for COVID. I know in New York, for example, a couple of weeks ago, they started a study of, I believe, like 10,000 patients for chloroquine. How long do you think it is before we obtain fairly concrete information on how effective these drugs are?
I think it's likely to be, we're starting to see some trickling out. We've already seen data been published in the New England Journal about certain HIV drugs that have been repurposed and they failed in a clinical trial. There are multiple trials going on, even in Pittsburgh, with hydroxychloroquine, which is related to chloroquine. And I do think we're going to start seeing data within the next couple of weeks. It does take time to enroll patients. And initially, the highest number of cases were in China, and we've had some of those trials halted there because China seems to have not many patients now to actually enroll in the trials. So that's taken some time to transition these trials to other places where there are hotspots and enough cases like Italy in the United States. But I do think within a matter of weeks, we'll start to see some new data. There's even been data released today on Gilead's drug remdesivir. So that it is coming out, but it does take time to get those clinical trials and to get enough data to be able to actually say something meaningful about it when you publish them.
Cool, thanks so much. Ash has a question, but I just wanted to ask one beforehand. So you talked about sort of the conditions about reopening the economy and all of that. As students, obviously we're taking classes online and that's less than ideal for us. And especially as MBA students, paying for the social experience is a big thing that we are looking forward to. Do you have any thoughts on universities and schools reopening either classes or the facilities open for students and how that might differ from other situations?
I do think that universities are going to be harder to get opened because many people assume that university students can do distance learning better than a sixth grader can. So there's going to be a higher threshold to open the universities. And I think even today in the press conference that was done in Pennsylvania, there was some hesitancy to talk about opening schools in the fall, universities and colleges in the fall. So I think that this is going to be a bigger challenge. I think you can do social distancing easier. I think it's much easier to have people behave themselves there in a college in terms of versus a kindergarten class. But I think it's going to be a challenge for many people, and many universities may think about liability concerns if they have people coming from all over the country to go to college. Again, I think this is probably going to be a state-by-state decision, and it's not going to be universal, and it's going to be very difficult to predict exactly what's going to happen because it's really going to depend upon your governor of the state that you're in. And I think the one in Pennsylvania doesn't really show any enthusiasm about opening anything right now. So I'm not sure what will happen, but I do think the point you make is important, that you're paying tuition, not just for the classes, but for the social and the networking that you're going to do for the rest of your life. So I think that is an important thing that needs to be taken into account of that people aren't.
Thanks so much. Our next question is from Ashley.
Hi, doctor. I heard that some people who are otherwise asymptomatic have a specific symptom of being a nosemic or having like no sense of smell. I'm curious as to what that mechanism is, given that it's usually, usually that happens with an upper respiratory infection, but people who have no other symptoms may have this lack of sense of smell. I was just wondering if you could touch on that.
Yeah, so this is one of the mysteries of this virus. We don't quite know why it occurs and if it really has been, and it hasn't really been studied in much detail yet, but it is a symptom that we've heard about happening, people losing the sense of smell. And it may be that the virus we don't know if the virus is directly invading the olfactory or the sense of smell, so the smell centers in your nose and in your brain, or if this is inflammation from the immune system that's causing it. So the answer is I don't really know exactly why that's the only sole symptom that people are having. Most people, like you said, do have other symptoms like congestion or fever or some other sign of infection. So this is one of the mysteries that we don't understand about this virus and its infection in the nose.
And a quick follow-up is, do you know of any patients who've had just this symptom and who've recovered their sense of smell, or do you have any prediction as to this could be a long-term problem?
I do know one person that doesn't have a confirmed case never had testing, had lost a sense of smell in the New York City area, and now that sense of smell has recovered, but that's an anecdote, and I don't even know if it's related to the coronavirus.
Okay, thank you.
Cool. So we're running up to the end of the doctor's time. We have to leave at 6:10 for another engagement. So I just wanted to ask one final question, and then we'll do some closing remarks. So last question that was submitted was regarding the future, and we touched upon it a little bit, but regardless of state by state, when do you think life in the US in general will return to normal, and what does that new normal look like?
I think I alluded to that there's not going to be mass gatherings. It's going to be a lot more social distancing that happens at usual things that you do in terms of restaurants, in terms of social events, in terms of plays and music festivals. All of that kind of stuff is going to be very difficult to see happening until we have a vaccine. There's going to be increased reliance on things like we're doing right now on Zoom, more people watching things online. I think people, even when social distancing recommendations are eased, are going to have a difficulty. There are going to be some people that are still reticent to do that. So I do think that we're not going to have the same society that we had on December 31st, on June 31st, on July 31st. It's going to be a changed society, and that's what happens with pandemics, that they change society. But hopefully we get to some semblance of normalcy, and that people are able to pursue what they want to pursue eventually. And I do think this is the real cost of pandemics, and this is why pandemic preparedness is so important, because that's what we've given up and what we've lost.
Cool. Thank you so much for taking the time to join with us. I hope everyone here in the audience enjoyed and learned a little bit more about the pandemic that we're living through. So on behalf of the Healthcare Club, thank you so much for joining us, and we hope to have you back again soon.
Sure. Thanks again.